Hello, everyone. Welcome to today's podcast where we explore glioblastoma, its prognosis, and the profound challenges it presents for both patients and their families. We are joined by Dr. Minns, who is an assistant professor in clinical research at the University of North Carolina, Wilmington, where she leads an interprofessional research team of nurse scientists, clinical research graduate students, and undergraduate students from the School of Nursing and Clinical Research, and she also partners with the former care partners of patients with GBM. Dr. Minns has been working in the translational medicine since her PhD studies at the Giselle School of Medicine at Dartmouth. Her current work focuses on mixed methods research to elevate the voices of primary care partners of patients with GBM and to help design interventions to better support the caregivers and their patients. She is also an advocate of the family centered care model, a model that includes family members in medical decision making for patients with GBM. In addition to her research interest, she is also a former primary care partner of a patient with GBM. Her experiences led her to be the founding member and the current executive board member of the Glioblastoma Support Network, a non-profit organization focused on providing educational resources for patients with GBM and their care partners. Additionally, we are also joined by Dr. Mansouri. He's a neurosurgeon dedicated to clinical trials and is devoted to simplifying and supporting patients in the clinical trial processes. He does his research in the adult brain tumors, specifically liquid biopsy and early phase surgical trials. So, Dr. Minns, let's start with you. What motivated your focus on the experiences of caregivers for the GBM patient?
Right. So thanks for that nice introduction. I had an experience as a primary caregiver of my spouse who had glioblastoma. And with my research background and training in biomedical research, it was surprising to me some of the challenges that we faced during his disease trajectory. So I found that these were common issues once I reached out to other care partners, and I really wanted to become more involved in helping to highlight these with an aim towards affecting change in the way that we help families and care partners and patients navigate this terrible diagnosis.
So, this personal connection must bring a very unique perspective to your research. So, beyond the direct impact on patients, how does GBM affect the lives of their family, especially the caregivers?
Yeah, so and Dr. Mansouri can probably highlight this as well. Most of the time when patients present with a glioblastoma, it's an emergency situation. They have some neurological symptom that sends them to seek medical care. And then very soon after, there's imaging and other medical tests that confirm some sort of an abnormality in the brain. And, with many types of cancers, one of the first steps is a biopsy. So these patients will have brain surgery very quickly after initial presentation with their symptoms. So from, the patient's perspective and the people who love them, the days are going great. And then suddenly you have this very scary neurological condition that leads to a very scary diagnosis that affects the way that those patients think, the way that they function. And so there's a fast adaptation that has to occur with the patient and with their care partners in order to continue the navigation through the disease.
Sounds like the support from the onset is very crucial. And going back to your study, it focuses notably on also the female spouses. Did it offer any insights into the experience of caregivers from other demographics?
Sure, that's a great question. Our initial study was on female spouses of patients who have glioblastoma. There are more men that are diagnosed with glioblastoma than women. However, these findings do, span across genders and ages. And so, although this study that we did was focused on the female care partner experience, it can be applied to other care partner scenarios. The themes are very similar amongst those groups.
So, Dr. Mansouri, turning to you, given the insights shared by Dr. Minns about the diverse and the evolving needs of caregivers, How do these family dynamics and the need for the quick adaptation impact the treatment options that are proposed for the GBM patient?
I think that's a great question. And as Dr. Minns mentioned, no one's really prepared for this situation, neither the patient or their loved ones. It's not like you get a quick handbook on how to prepare for that situation. You just thrust into it, everything's going fine, then you have a seizure or some sort of neurological visit, and you're laid with the terrible news. I find that more and more that the family is an integral part of the process. So right from the get-go, there's lots of information to digest. What could this be? Could be this tumor, could be that tumor. What are the options laid ahead of us in the short term and the long term? And then once you have some understanding of the diagnosis, there are lots of different doctors to navigate. How do you understand who's your surgeon, who's your radiation oncologist, who's your neuro-oncologist, what's the differences? And then unfortunately, with glioblastoma and brain tumors, unlike some of the other systemic tumors like lung and breast, it affects the brain. So inevitably the cognition or physical aspects of an individual is affected too. So they need help either navigating the understanding of the situation or physically getting around. And I find that at every stage, there's something different to expect. So first is the diagnosis, how to digest the information, how to look up treatment options, including clinical trials, and then going through with the surgery. And then once you recover from the surgery, then there's the chemotherapy and the radiation. And at the beginning, that can be very intense. It can be daily treatment that you need to go to. And some of these treatments, not all, need sedation. So the patient definitely can't drive themselves to it. So the family is very much involved, driving them, taking time off work, making sure they're okay from that perspective. And then if you could ever say this when it comes to glioblastoma, but once you're beyond that early intense period, then you get into the other during sort of remission, you have to think about the other stuff like short-term and long-term disability, FMLA forms, potentially looking at supplemental health insurance, how to manage the finances, who's going to be power attorney, et cetera, et cetera. So the needs from the family and care partners shifts dramatically depending on the stage. And I think as the healthcare team, we have to consider the whole patient and adapt our recommendations as part of a bigger picture in terms of the impact it has on the patient and their wishes and the ability of their family and their care team to support them through all these. So Laurie, there's a critical role to be played by the care partners, in particular in the post-operative course, be it the initial surgery followed by chemo and radiation. In your research, did you find any that the caregivers felt prepared for this role? And if not, what were the particular surprises? How can we, clinicians, better prepare them potentially in the future?
Right. I think you explained really well kind of that fast diagnosis and then a series of medical treatments and medical team members that come in. It's a lot of information to process in a short period of time. In terms of, I think even the person with the strongest background, even in our study, people who've been working as nurses in oncology for 25 years felt blindsided by the diagnosis and the practical issues associated with caring for their patient with GBM. And that really extends from logistics to how are we going to get to and from appointments, who's working and who's not working, how are we going to pay our bills? Do we need a second opinion? Is that local? Is that far away? How can we figure out what the best option moving forward is? So, one of the things that we found in our study was that caregivers were overwhelmingly unprepared for the changes that were ahead of them during all of the phases of the disease, from that time that you described of that initial diagnosis where they're getting chemotherapy and radiation, if that's what they choose to do, where they see medical providers every day, to that period of time where you're kind of just waiting for the other shoe to drop, right? They'll go in for some imaging and probably monthly chemotherapy. And so in that phase, a lot of changes can happen. They're somewhat subtle, but the caregivers from our study indicated that they needed more education about what to expect during each of these phases so that they could not only be better prepared, but also provide better care for their patient, their partner, their family member that's been affected by this. So I guess to answer your question, overwhelmingly not prepared is what care partners reported to us.
I'm going back to your research quickly. Your research also mentioned that you involved a large group of caregivers. So, could you explain how you gathered such a diverse set of experiences?
Right, that's a great question. So glioblastoma is a relatively rare cancer. It affects about 3 individuals per 100,000. So care partners may not run into each other organically within the community. Instead, they'll reach out to the social networks. So using social media, and in fact, that's what I did. I reached out within social media and was very quickly linked to support groups that were designed for care partners of patients with GBM. And so from interacting with that group, there was one of my colleagues who's a co-author on this paper, actually, Lisa DeSaltes, started a letter writing campaign in order to collect the data for this study. And then I became involved because of my background in research. And so we were able to really, as a grassroots kind of movement, elevate the voices of these caregivers, care partners of patients with GBM. We asked them to write letters. They're about 500-word letters, and we collected 101 of those. And then my research team was able to analyze those and help understand what the pressing issues were from that kind of grassroots movement.
I must
So
say,
from that, we were able to get a large data set of experiences from primary care partners of patients with glioblastoma.
yeah, I must say huge kudos to you and Lisa for starting GSN. I think it was a highly unmet need, and you guys have addressed that. And I've done some surveys as part of my research, and definitely the response rate is not as high as this was. So this definitely shows the motivation and how invested people were to make sure there's an answer. I was highly impressed with the depth of the research, and one thing that caught my attention was the methodology. Could you elucidate on the reflexive thematic analysis for our listeners and for me, and how you used it for the analysis of caregivers' narratives?
Sure, that's a great question. So this method was developed by Braun and Clark. They're very accomplished qualitative researchers. And reflexive thematic analysis consists of 6 steps. The first one is really data familiarization. So team members within my group would read a subset of letters and kind of start to identify what was being said with those. You can take handwritten notes. We used a software called NVivo, which is commonly used for this type of research. And then the second part is the systematic data coding. So what happens is each team member starts to go through the letters and highlight regions of the text that are associated with certain types of experiences, and those are called codes. Then those codes are used to generate themes or preliminary themes. And then as team members, we all go back through, so we have data congruence, so make sure that the method is reliable. And then we start develop and revise these themes, which is step 4. In step 5, we now start to name those. So sometimes you may have a code, for example, somebody might be talking about FMLA problems. So where does that code come into? Is it a financial difficulty? Is it like a work-life balance difficulty? Where does that go? And so we have to kind of really take a step back to make sure that we're honoring what the words are, or what the feelings, thoughts are conveyed within these letters, and do our best to be able to highlight those. Once we do that and we work as a team, we go through this iterative process. And it took several months to go through this. Then we finally have the themes identified, and then we start to write the report, which is what this paper that we published in BMJ Open reflects.
Super cool.
Does sound like a very comprehensive. Also, Dr. Minns, your study does shed light on living with progression as a very notably challenging period. Could you help us understand the specific obstacles that the caregivers encounter during this?
Sure. So like Dr. Mansouri had said earlier, within the illness or disease trajectory, there's that acute stage, but then there's a lot of medical intervention. And then there's this, it's been coined by others as this living with progression phase, which basically is the end of daily radiation if patients opt for standard of care, and then they're followed monthly, where they take oral temozolomide 5 days out of the month, and they get imaging about every 2 months by MRI. So the number of medical visits drops significantly during this time, unless the patient has like really a big change in status or symptoms, then they'll be seen by their provider. But all of that first kind of really acute interaction with the medical team basically just drops right down. So now the patients and their care partners and their families are just kind of trying to get through daily living. And there are many deficits that really start to appear during this phase. And family members are typically the first to see these because they live with these people, they love these people, and they can start to see them. So there may be changes in mental status, changes in memory, changes in physical ability to do things, stamina, a whole host of things dependent upon where in the brain the tumor or tumors are located and those effects on the body. And so at that time, probably because there are fewer medical visits that are occurring, and then also that's a time when the patient's symptoms tend to get worse, the caregivers are not really prepared for what to do now at this stage. And so they really, when we mapped these themes against those different phases, we really found that they just wanted more information about what to expect. What kinds of changes might occur in the patient? Is their patient going to be able to go back to work or not? And how does that impact their family finances? There are just a lot of things now after you're in this initial shock period that now you're starting to kind of fall into life with this progressive illness.
It's quite understandable, especially like the way you were saying about the uncertainties regarding the symptom progression, and then again, like the financial concerns. There seems to be like a continuous anxiety that they have to go through. Another thing in your a recurring theme in your finding was also about the unmet educational needs. So, what information were caregivers seeking out the most?
Yeah, so the care partners really want to know kind of what to expect, right? And so what do we think will happen with my loved one, and how can I best prepare for that? Whether that be, again, these cognitive or memory changes, behavioral changes, physical changes, to, how long are we thinking about? What do I need to look for? Do I need to start thinking about having supportive equipment at home? These kinds of things, just so that they can keep it on their radar. And I think it's really important to note that every patient with glioblastoma has their own disease trajectory, and some do really, really well, and some don't do as well. And I think, with that caveat in place, it's really still important to let caregivers know, kind of what could happen. They want they definitely want more information about the disease and its prognosis, just so they can prepare. Because we know there have been several studies, and one in particular that shows that caregiver mastery is predictive of patient survival. And that's probably also linked to the quality of life. So caregivers are really important as team members for the patient, and for the patient to do as well as they can with this devastating diagnosis.
Dr. Mansouri, would you like to add something to this?
Certainly, the way we monitor patients after they have completed their initial round of therapy is with brain imaging, as Laurie mentioned, every couple of months, and follow up. The period in between these imaging sessions is quite stressful, and in fact, there's a term for that. People call it scanxiety, and it's just the fear of unknown. It can be very overwhelming, and this doesn't necessarily pertain to clinical trials specifically. It's all stages of the health journey. I think everyone is different, and their approach to managing this stress is also different. So, you can't have a one-size-fits-all strategy. What I can say, though, is to try to be as informed as possible, ask as many questions as you can from the healthcare team. Don't be shy. That's what they're there for, And nowadays with the portals and all these messaging strategies, your healthcare team is pretty accessible. So feel free to use that resource. It's easier said than done, but having the mentality of managing the things that you can control and letting go of those that you cannot, for as much as you can. So those are some of the observations that I've made and some of the thoughts that I've developed on that.
So, Dr. Minns, going back to your research, how has the Facebook group We Are the Vives of GBM, and this is our story, proven to be a valuable resource for these caregivers?
Yeah, that's a great question. Like I said, because the incidence is relatively low, it's hard to organically meet people who are going through the same journey or similar or parallel journeys as you. So it provides a place for mental health support. It's a shared experience community. It's the club that nobody wanted to join. And from that, there's just an inherent feeling of welcome and compassion. And also, those groups really can provide some practical information. They can bring up, issues that they have faced that other people who are earlier on the journey have not. And so they're able to kind of help caregivers, at least they anticipate in some ways, some things that might be happening. There's that saying, you don't know what you don't know. And nobody knows what they're going to go through when they start this. And so having that support, that peer support, and really providing some practical help along the way can be really beneficial.
Coming back to you, Dr. Mansouri, in your experience, how can the medical community better leverage social media platforms to support both GBM patients and their caregivers?
Yeah, there's definitely no denying that almost everyone nowadays is on the internet trying to get information on their health, whether it's just, what supplements should I take, or, something as serious as what is glioblastoma and how to manage it. And this information can be sought from anywhere from Google, Facebook, or TikTok. And it can be great if the information is reliable, but it can be problematic as it is challenging to sift through all the vast body of information and decide which one is correct and which one is not. I think this is where we come in as healthcare professionals, embrace the current situation and control the narrative. So by being involved in social media, you can, contribute to creating healthcare content that can be a source of guidance or at least pointing people in the right direction. And that can be extremely helpful. Of course, there's the issue of bandwidth, but I think we already have a lot on our plate, but not everyone, not everyone's Dr. Oz, but collectively we can do our part to make this better. And Laurie, we talk about how do you determine what medical information is reliable. I think these Facebook groups are all very helpful, but there's also a challenge as to pick the right group for you. I'm just curious, how does one go about the right group?
That's a good question. And, I'm a little biased because I've been reading scientific literatures for the last almost 30 years. So I'm good personally at finding that information. I think what is helpful is if you can find social media support groups that are hosted by a reputable place. And that could be with connections within the medical community. For example, I think about things like using resources from the American Brain Tumor Association. It's a great place to find good, reliable, accurate information about GBM. And then, go to their social media sites. We also, of course, like the Glioblastoma Support Network has a presence on Facebook, and we have a website. So, the hope is that the information that these groups that actually know kind of what's happening will be louder than the other ones that are talking about, just like with everything, you have people who believe very fervently about certain types of interventions that don't have any FDA approval or efficacy, because they can be very loud. So I think really focusing on social media groups that have an affiliation with a professional organization or nonprofit is the best way to go.
Very good point. So, in terms of where to go for healthcare professionals, in terms of supporting GBM care partners, how might caregiver needs assessments be implemented in a clinical setting? So, from the perspective of a healthcare professional, what actionable steps would you suggest to make have better support systems in place for the care partners?
Yeah, that's a really great question. In fact, our team is looking to kind of address that situation now. We look to our colleagues and my collaborator, Dr. Barb Lutz, and her collaborator, Dr. Michelle Kamisha. work in the stroke space, and they created a validated instrument called the preparedness assessment for the transition home, meant for patients in rehab. And it's given to the care partner to answer a series of questions, 25 different questions that really assess some of the different care partners' ability to, are they committed to this? Do they have capacity to take care of their patient? And what are the long-term implications of the disease? So we can look to tools like that that have been validated in other patient populations, and then move toward validating those within the GBM space, really to provide not only an assessment, but also that instrument is an intervention in and of itself, because it prompts care partners to be thinking about things that they may not have thought about. You know, for example, one of the questions on this assessment is, do you know what your, you know, patient's prognosis is? And you rank it on a scale of 0 to 4, 1 to 4. And from that, then that can be paired with a particular intervention. So that might be talking with the medical provider to get on the team, really asking the question, what is my patient's prognosis? So those are some of the ongoing projects that my team is working with. And really, we hope to deploy these in different clinical trials, either as standalone or as add-ons to ongoing trials, really to see what's happening with the caregiver.
That's brilliant. I love it. So what about assessment of how much patients and their care partners are ready to know? So I try to ask as many questions about their understanding of the current situation to help calibrate how I take the conversation. Or are there practical tools or skill sets clinicians should ideally know about?
You know, I think I'm not a health literacy expert, but what I can say is that I would advocate best practice would be to ask those questions. You know, do you understand this? Can you explain it back to me? At all, many of the interventions that you have throughout the process, because you can imagine when somebody is first diagnosed, they're going to have very different questions than once they've, you know, they're in the middle of their radiation and chemotherapy versus later on. So I think continuing to ask those questions and have an ongoing dialogue and really partner with the patient, you know, that patient-centered approach, and then also involve the primary care partners with that, because they can provide insight that the patient might not be on their radar. And so really advocating for good and ongoing conversation about, you know, what do we know? What do you need to know more of? And again, it's you don't know what you don't know. And so, and it's not like this is the type of disease where people get diagnosed and then they will be, you know, your family hopefully is not going through this process again. Like this is something that you don't prepare for, you're in it, and then you're in it. So we don't have a lot of practice in knowing what we should be looking for.
Yeah.
Thank you, Dr. Laurie, for this, and Dr. Mansouri too. Before we close the podcast, I just wanted to quickly come back and ask you, do you have any final thoughts on all these approaches that you mentioned, how these could actually be integrated in the standard of care and, just help them transform the entire caregiver patient experience, both from, as a GBM care partner perspective and from the healthcare perspective?
Laura, do you want to go first?
Sure, I'll go first. What I think is really important, and one of the things that we found from our study was, those themes that I talked about earlier. We identified 3 themes from those letters that detail the patient experience and 4 themes that detail the caregiver experience. And what really stood out to me was that care partners are excellent record keepers. They keep track of everything. They know, at least the ones that we saw within this study, they know the dates and times that their patient was seen, which interventions occurred. They become very good at understanding the different medications that they're on. And so I think if we can kind of shift the approach to, this care partner is instrumental in delivering the care that we need for the patient. And then we can look to those care partners for help with other things too. And we should really involve them in some of the clinical trials that are within the GBM space, because they're truly the best ally. I mean, they're responsible for all of the logistics of getting the patient to and from wherever it is that they have to go. Their memories typically are working quite well. And they tend to be pretty organized because they're so invested in this process. So I think really from my perspective, from the care partners that we saw in this study, is they want to be involved, they want to be valued, and we would advocate that the medical teams see the asset that's in front of them and use it.
Absolutely. And I think from my perspective, something that we often mention but necessarily perfectly address is the problem of using too much medical jargon in our conversations with the patient and their loved ones. And we also must not forget the issue of language and cultural barriers. So in addition to making sure our patients and their loved ones are aware of the challenges ahead, have access to these awesome tools like the PATH tool, we must also ensure that they understand all the facts that are coming their way. So ideally, I would like to see more research dedicated to developing tools that break down these language barriers, simplify the medical jargon, while also incorporating the support tools that investigators like Dr. Minns are working on.
Yeah, that's just such a great idea. I think that would go so far. I mean, really looking at that, simplifying terms and making it easier for patients and their care partners is really, really important within this space.
We couldn't agree more. I think this is some of the things that even as WeTrials, we are trying to work on is simplifying these languages, making it more accessible to people, empowering them with this education, and then supporting them throughout this process. So we come towards the end of our podcast today, and I want to thank you, Dr. Minns and Dr. Mansouri, for your valuable insights and for sharing your expertise with us today. To our listeners, we trust that today's conversation has deepened your understanding of glioblastoma, highlighting not only the medical challenges it presents, but also the crucial role of caregivers in navigating this journey. We hope this episode inspires continued dialogue and support within your communities and helps foster advancement in both care and treatment. Join us next time as we continue to bring light to such critical topics in healthcare. Stay informed and take care.